Well, thank you, Mr. Chair. Thank you to all the witnesses for your participation and your testimony today. As several of our colleagues have raised throughout the course of the last year, I want to ask questions specifically concerning the aspects of COVID-19 and its disproportionate impact on communities of color and lower income communities. And just using my own home state as an example, in California, the death rate for Latinos is 22% higher than the statewide average. The case rate for Pacific Islanders is 32% higher than the statewide average. And the case rate for communities with median incomes below $40,000 a year is 37% higher than the statewide average. COVID-19 has clearly exposed a large underlying racial and socioeconomic disparities in our healthcare system, in our pandemic response plans, particularly at earlier stages, and the disproportionate risk for essential worker population. So, question for Ms. Slurry and Mr. Nimich: how can we ensure that our pandemic response plans and our disaster response plans more broadly take into account these underlying issues of inequity?
You know, it's such a terrific and important question that needs to be considered really, really comprehensively. We talked a lot earlier about planning, and certainly racial ethnic minority and low-income communities and others need to be involved in the planning process from the get-go. They need to be understood. Every single time we think about doing surveillance, that we think about doing data collection, that we think about getting a complete picture of what the situation is, we need those sort of data elements about race, ethnicity, income, social vulnerability index of where someone lives. And frankly, that has to be a reflex part of every single bit of analysis so that we can identify as quickly as possible the populations that are the most adversely affected and address them as quickly as possible. But also operationally, you have to have representatives of all of those communities with you at the table and part of the operational plan to get going. You know, in a nutshell, it's just end-to-end looking at everything you do through this lens of equity.
Senator, it is one of the toughest questions that we have to deal with, and it is a challenge. It is a community, the underserved and economically disadvantaged tend to have less trust in the federal government, tend to have less trust in what is being said. We need to encourage them to participate in the planning and the understanding, but we need to reach out to those community leaders that are able to explain. I can tell you from a FEMA perspective, the ability for that community to request the assistance that they deserve is often limited. They don't even understand that there are opportunities there for them to take advantage of. And finally, when they do take advantage, they are often put in difficult situations, multiple different questions, multiple different programs. I'm registered for a state program, a federal program, and it becomes overwhelming for them to be able to participate in and provide the details that we as a government require before we're willing to give out aid.
Thank you. And look, what leads to that question is a recognition of what the data is telling us. So my next question for a couple of you is not just underscoring the value of data, but fundamental science. Many of you have mentioned in your testimony, science is the foundation of our response measures to disasters. Science and research guides the public health recommendations and directives, including during COVID, social distancing, masks and other face coverings, vaccine creation and distribution plans, etc. So without basic research done through NIH-funded institutes, our responses and vaccines could have taken much, much longer to develop and complete. So Ms. Slurry and Ms. Gerberding, can you both comment on how we can more effectively use data and research from the COVID-19 response to improve our responses to future disasters and pandemics, and what kind of data might have been more helpful earlier in the pandemic as, again, a case study to inform future emergencies?
Sure. One of the first things I would note is that in prior crises, we've pulled together early and often with the help of the national academies, developed a research agenda that prioritizes the most important questions to ask and answer as a country so that we can get on top of that quickly. Unfortunately, that really didn't happen. A second thing I would want to note is that science includes social science, includes anthropology and sociology. And, here, I think we missed for a long time, as Mr. Nimitz was pointing out, the way different population groups were being impacted by this. And I think social science brought to bear early on would be critically important. And then third, as I said, to always look at the population subgroups that you think are going to be the most vulnerable. And sometimes you're surprised about who they are, but to be able to have that ability to do that. We have to be able to continue to fund science, and we have to be able, as I testified, to protect the integrity of our science agencies, to do science and to speak the truth about results. I think that last part, while we haven't dwelled on it, deserves a lot of consideration.
Thank you.
Yes, I will add to what Dr. Lurie said, because I agree with her entire statement, and especially the component of the National Academy of Medicine contribution to setting the research agenda, is that we need practical science as well, just nuts and bolts, like do masks work? It took us a long time to really establish that this was an aerosol virus. And that is something that had we set about finding that information early in the course of the situation, we might have been able to have better guidance up front about the importance of masks and what kind of masks and how well they work, et cetera. So there's a whole set of practical questions that come up in any outbreak, but were certainly critically important in this one, especially with the large degree of high titer asymptomatic infections. I think a second aspect of this really relates to how we can build the science of the new tools that we need. As mentioned earlier, the data tools, the artificial intelligence, machine learning that can take advantage of the information that we do have and create knowledge out of it. And the third thing I would say, for a long time, there's been a paucity of investment in what I would consider to be public health research. Not all of the research done at the NIH is germane to some of these practical translational problems that I'm talking about. And CDC does really need a bigger research budget so they can get the best and the brightest people in our academic environment, our medical schools, our schools of public health, our social science schools, to get onto some of these issues and really build out the science base. It'll serve us well in the short run in this context, but it is something that we need foundationally going into whatever the next new emerging infection is.
Thank you both. Thank you, Mr. Chair.